Good afternoon, everyone. I'm Cindy Crook, Director of Marketing at Duncan Regional Hospital, and welcome to DRH Live. We're here with two great guests, but before I introduce them, I want to tell you about something. We have a campaign that we've kicked off this year called Stop the Stigma. You may have seen some of the billboards that we have. It's a campaign to get people to talk about mental illness and not be ashamed about it. And a couple months ago, we had a guest speaker, an author, Kate Fagan, and she wrote this book, What Made Maddie Run, which is an incredible book about her story about Maddie and her struggle with mental illness. Well, I have this book and it's autographed by Kate, so we have a little contest going on. If you will tag 3 friends with this video, all your names will be put in a drawing to win this book. So tag your friends and listen to these 2 ladies that are going to tell you some great information about depression and suicide. So I want to introduce Amy Toomey. Amy is the manager of our Inspirations unit here at the hospital. And next to her is Paula Proctor. She's a nurse and she's the director of our psychiatric services and our Horizons unit. And I'm going to let you ladies go ahead.
I want to talk to you today first about what Inspirations is. It is an outpatient counseling program for senior adults that is offered here at Duncan Regional Hospital. The average age person that we see is approximately 70, but we see patients as mature as I like to say is 99, and then some younger patients down into their 50s. And we see people that are struggling with all kinds of mental health concerns, including depression and anxiety, as well as bipolar disorder and schizophrenia. We also see people that this is their first mental health experience, so they've never been to counseling or seen a psychiatrist before. And we also see people that are considered chronically mentally ill, but perhaps have struggled with bipolar disorder or depression throughout their lifetime. We provide group counseling services as well as psychiatric medication management. And we also provide transportation for our patients that live in nursing homes or assisted livings, or perhaps just have some anxiety about driving.
I'd like to tell you just a little bit about what we do on the flip side of that, which is our inpatient care. We have a 12-bed unit called Horizons on the 4th floor of Duncan Regional Hospital. We also see patients who are 65 and older who have a variety of mental illness diagnoses or other kinds of problems that they might be experiencing. That includes major mental illness. We also see many patients who have various types of dementia, and we know that that's a big category of illness. So we hope that if you have family members, loved ones, or you yourself are experiencing issues and you kind of fall into the categories that we can help you with, that you will be sure and take advantage of our ability to provide that help for you.
And today, specifically, we've been asked to talk about depression and suicide. So I wanted to start just by describing what depression is, which for me, and according to some of the books that we read, depression is a period of sadness, hopelessness, or just feeling empty. And it can occur after a life event. For example, it can occur after the loss of a loved one, a financial challenge, a natural disaster. It can also occur after a diagnosis of a significant physical illness. Some people, too, have a predisposition to depression. Maybe they have family members that have struggled with depression or a mental illness in their past. And depression can have a very clear link from some of these things that I've mentioned previously, and sometimes we really don't know what causes it because there is a chemical component related to neurotransmitters in your brain that can affect your functioning and your symptoms. So when we talk about what clinical depression is, most people notice some changes in their functioning. For some people, they have significant difficulty sleeping. Maybe for most of their life they haven't had trouble, and all of a sudden they lay awake or they wake up really early in the morning. And for other people, it's the opposite. They want to sleep all the time. They don't have much motivation to get up or do anything. And a lot of symptoms of depression are like that, in the sense that appetite. Some people who have depression are very hungry and eat a lot and gain a lot of weight, where other people lose their appetite and so they lose weight. Depression is also characterized by just decreased motivation and decreased energy, and people who used to exercise or do crafts or participate in public or community events just don't really have motivation to do things that they previously enjoyed. And these are things that family members would notice. So perhaps people recognize these changes in themselves, or your friend that used to sit with you at the Rotary Club meeting just isn't there for several weeks in a row, or your friend that's in your Sunday school class just doesn't seem to be themselves. One of the more significant symptoms of depression, like I mentioned as part of the definition, is hopelessness. And people that start to think that things are never going to be any better. And accompanying hopelessness is thoughts of suicide, which I think is one of the big symptoms that people typically associate with depression. And that would be just a belief that the world would be better, that I wasn't here. Or they start to think about ways that they could end their life as a way of ending the pain, or the emotional pain, or the sadness, or getting away from perhaps the loss, or learning to live with life without someone that you really cared about. The good news is that there is treatment for depression. And of course, medication is one of those options, and seeing the psychiatrist. And what they tell us, though, is that the most effective treatment for depression is a combination of medication as well as therapy. And that can be group therapy or individual counseling. But outside of that, also, there are things that people can do. And most of the time, I just encourage people to take care of themselves. And that can be, maybe I really don't have the energy to get up and exercise, but I could go for a walk. Or I could take some steps to eat food that would make me healthier. Or I could make a phone call to a friend, because perhaps not everyone feels comfortable seeking professional counseling, but they have someone that they could trust and speak to. And typically people who are connected with others feel better about themselves and experience fewer symptoms of depression. I would also typically encourage people, if they have a priest or a minister, if they have a spiritual connection, that they return to that. If that means go to church, if that means meditate, to encourage people to participate in things that help them feel better about themselves. I think those are things that I wanted to say about depression, and Paula had some more specific comments she wanted to make about suicide.
Thank you, Amy. That's very good information that's been shared, and it's almost impossible to talk about depression without tagging that with the subject of suicide, which is a subject that needs much more talk. As Cindy mentioned earlier, with the Stop the Stigma campaign, we're hoping that that subject will be more freely talked about, so that we can actually provide help to those that need it. Every 40 seconds in the United States, somebody commits suicide. And if you stop and think about that, that's staggering. 30,000 people annually in the United States commit suicide. And in Oklahoma, we have the 8th highest rate of suicide in the nation, which we should be very ashamed about. We should all see that as a reason to take up arms and combat this significant and serious problem in our state. In Oklahoma, one suicide is committed about every 11 hours. And we really must do something about this. 700,000 to 900,000 people annually in Oklahoma seek treatment. That's how many people need treatment. Only 2 in 5 people in Oklahoma actually are able to receive treatment. Mm-hmm. And the largest cause of suicide is untreated depression. And as Amy mentioned, there's excellent treatment for depression, including therapy and medications, and maybe even some unconventional kinds of things. But this is an epidemic that we really can affect and do something about. Okay, so if we can do something about it, why do we not? Research shows us in Oklahoma that there's really 2 reasons why we don't, or 2 major reasons. One of them is access to resources. We don't always have resources that we need, or we don't maybe know where those resources are in the state or in our local region, in our county. The other reason is because of stigma. Cindy's already mentioned that at the beginning of the broadcast. And Amy and I deal with that every day in our job here at DRH, and try to do our part to eliminate stigma, but it's a very difficult thing to do. When you talk to family members who have lost loved ones to suicide, one of the major things they tell us is that my daughter, my son didn't want anybody to know. The reason they didn't want anybody to know how desperately they were feeling is because of stigma that they experienced when maybe their family or friends see it as a sign of weakness, or even worse, a sign that they're possessed, or all the other many stereotypical things that people conjure up about suicide. I briefly want to mention a few of the warning signs for a person who might be thinking about suicide, or even planning an attempt at suicide. One of the first things they may do is to start talking about it. They may engage you in a conversation. What do you think about suicide? Do you think it's the unforgivable sin? Do you think there's life after suicide? Those kind of things. So having that conversation with a person may be a first sign. Also, many times they'll start giving away their prized possessions. They may have things that are near and dear to their heart, and if they're already planning suicide, they may think that the person they're giving that to will be aided or helped with their emotional struggle once they're gone. It may make them feel better, in other words, to have maybe their Bible or some other memento. They may also make changes to their will. So these are many things that can be warning signs that somebody's struggling. They may obtain a weapon. We know that overdoses, in Oklahoma anyway, is the number one method by which people commit suicide. But also weapons are right up there, getting closer to the top all the time. They may also be experiencing strange sleeping patterns. As Amy mentioned, with depression, low energy levels. They may be using drugs and alcohol, or alcohol. They may have very, very low motivation to participate in their social life. As Amy mentioned as well, things that they used to enjoy doing, they may not be engaging in those activities anymore. And those, again, are really sure signs of problems. They may be engaging in self-harm, where they harm themselves in some way to see if they test themselves in a way to see if they're going to really be able to follow through and do whatever, use whatever method that they've selected to kill themselves. They may engage in risky behavior, just behavior that they normally would never engage in, and that could be any number of things. They also may have emotional outbursts. They may exhibit body language that will give us some signs. They may look down to the floor. They may not look you in the eye when they're talking with you. They many times will walk around with slumped shoulders, and those are also things that we need to watch out for. Another major factor is a past suicide attempt. If somebody has attempted suicide in the past, that makes them high risk for potentially attempting again. And one thing that I think is the most telling in terms of a stereotypical thing is we always hear people say, well, they were so happy. How in the world? I saw them yesterday, and they were experiencing a lot of happy events in their life. They were just getting their act together. They were doing well. And that is also a big sign. Happiness and being calm. That means probably they've already decided what they're going to do, how they're going to do it, and they've come to terms with it. And so they are happy and they are calm because their plan is developing as they want it to, and they're happy about that. So please don't wait till it's too late. Take note of the red flags that I've mentioned. Any of these alone don't mean a thing. Somebody can change their will and they obviously have no desire to kill themselves, or they may change their behavior. They may have anger problems. So we can't take any one of these signs alone and make the leap that they are going to attempt suicide. But collectively, they do paint a pretty serious picture. So Please take note of the hotline that we have available. That's the state hotline, 1-800-784-2433. And the best thing you can do if you encounter somebody who you're concerned about, or if you yourself are concerned that you're struggling with this, get help. Most people have access these days to computers, and one of the best websites that you can go to is suicide.org, and there is an immense amount of help for you if you access that. But please, get help. We have resources here in Duncan. You can call the hospital. You can call the emergency room. We have professionals who are really, really waiting and willing and ready to help you at least get into contact with the help that you need. So don't hesitate to do that.
I do have some questions. I want to remind everyone, if you tag 3 of your friends and yourself, your name will be put in the drawing for the book by Kate Fagan, What Made Maddie Run. I have some questions on the suicide, but we did have a question online from Keith, and his question was, do you work with the VA for veteran care?
I would say yes. I mean, we coordinate services with anyone that is willing to work with us. We don't have any specific contracts or connections with them. We have in the past treated patients who are residents at the VA Center in Lawton. And of course, the hospital avails themselves, and we provide those opportunities. But I don't know of anything specific as far as that. But we do see veterans. We actually have treated a number of World War II veterans in the past at Inspirations, and also a few Vietnam veterans.
As well, on the inpatient side, if a patient does need to be hospitalized, we do take veterans and even veterans' families if need be. So I would say, like Amy, that yes, we do work fairly closely with the VA, not in specific programs, but just trying to take care of whatever the veterans' needs are.
Great. Going back to the suicide question, if you happen to hear Kate Fagan talk, one of her comments was, we as people tend to see people and we say, hey, how are you doing? And we sometimes really don't mean it. We're just trying to be polite. But she was saying that we need to really ask people. So if you feel that someone, a friend or a family member, may be contemplating suicide, her suggestion was you really need to almost come out and ask. Well, that's really hard to do. So between the two of you, do you have any suggestions on, how do you get that person? How do you talk to that person? What questions could you ask or something like that? I'd be interested in that.
My perspective on that is that it's better to be very straightforward and use terminology that means what it means. Many times we'll hear people kind of skirt the issue, which it's such a serious issue that I don't think it needs to be skirted. If I encountered somebody who I felt like was struggling with this issue, I would in private tell them that I had concerns, and I would tell them the reasons. I'm seeing body language, or you're talking about it a lot, or whatever, and I would just simply ask them, do you intend to harm yourself? You can even say, do you intend to kill yourself? I think that's totally appropriate. If you don't go there, then there could be a place and a time where you would be very, very remorseful that you didn't. Many times we have to examine our own values and how much stigma we place on mental illness in order to have those conversations. I would also say, if you cannot bring yourself to have direct conversations with those that you feel like are struggling, please find somebody that will, because it's obviously a very therapeutic thing to do. They may not admit it to you, but I think you can put a better picture together if you're very straightforward.
I would agree with what Paula said. The other thing, I think people have the apprehension of asking because they're fearful, well, if they're not thinking about it, then I've given them the idea. But I disagree with that line of thought. I think it's absolutely best to be direct with people. And people who are really serious about contemplating suicide are not likely to tell others. And so point blank asking them makes it more difficult for them to decline. And so that does open the door to have a conversation with them. And like I said, most people, when they approach seriously, when they have their plan or thinking about implementing their plan, want to know, I mean, they're missing that connection with people. So if I was to have a conversation with Paula where she asked me and she cared enough to ask me, then maybe that would be enough to say, there is one person in the world that I mean something to or is going to notice if I'm gone.
Piggybacking on that just a little bit, unfortunately, we're seeing a lot of kids, 18 or under, either successfully committing suicide or at least trying. And we all know as youth that's a really hard, so it's really even harder, I would think, as a youth. So what would you recommend that if there's a 15-year-old and his 15-year-old friend may be thinking it, that's hard for them to go to? Who would you suggest that maybe they could go to let them know that their friend may be thinking that, teachers or any suggestions?
I think that age range, it is difficult, but we also know that 35% of the suicides that occur in the United States are committed by 14 to 18-year-olds, and that's a staggering thing. We've had experience with that in our own county just in the last couple months. And again, they need to approach their school counselor. They need to approach their Sunday school teacher. They need to approach their recreational football coach or a school coach. They need to approach their parents if their parents are engaged and ask them what they need to do. The most important thing they can do is just reach out to someone, and hopefully someone, maybe not in their peer group, but someone who has a little more ability to direct them properly. Their family doctor, their pediatrician, maybe their neighbor's a nurse, maybe their neighbor's a therapist or a teacher. And the most important thing is to take it seriously and err again on the side of caution and get them help.
I'm going to switch over just to the depression talk, and either one of you can chime in. So what's the difference between grief and depression?
For me, grief has various stages. And we would expect for people who have experienced significant loss to have some of the same things that I mentioned when we talk about what symptoms of depression are. The difference for me in grief and depression is the hopelessness component that goes along with depression. People absolutely experience grief, and we do grieve people that we've loved, and we also grieve our sense of independence and who we are. I mean, a lot of our older patients are struggling with what value do I have, so we can grieve numerous things, but the depression component adds that hopelessness to it. And hopefully, as we grieve people that we've lost, we do see transition through stages of grief. If it's Kubler-Ross's research about being angry and bargaining and some of those types of things. And to be clinically depressed, by the big book definition, we would need to experience these symptoms for at least 2 weeks. And there has to be, there's a whole list. I only gave you some of them. There's approximately 10 symptoms of depression. You have to have at least 5 for this period of time, which is pretty technical. I wasn't sure people were super interested in that. It's boring snooze, right? So, and like I said, with grief, there is also an ebb and flow to it. I mean, people may be doing well for several weeks or a month, where they go days where I can cope with life, or, that they don't reach over in bed to touch their spouse that's no longer there. But then they'll have an anniversary date or someone's birthday, or they'll hear their song on the radio, and maybe they have a renewed triggering or increased emotionality that they haven't experienced in some time. Is there something you would say, Paula?
I think that answers the question well.
Okay. And then you had mentioned that you can treat depression with therapy and medication, and you hear people, I don't want to get on any kind of drugs and stuff. So will a doctor work with them? If they say, I do not want to take any medication whatsoever, I mean, can that work too?
Yes, I mean, antidepressants or anti-anxiety or sleep medicines all have a purpose and a place, and not every medicine is for every person, and vice versa. So I think a physician has the skill of recognizing when it's good for people and when it's not, and also in each patient what is going to be best for them and what is their motivation point. So no, absolutely people can cope with depression with things besides medicine. And I think one of those things, like I said, sometimes it's doing the opposite of what you really want to do. When you're depressed, you want to stay in bed, but what do you need to do? You need to get up. Do you want to talk to people? No, but is that what I need? Yes. So I do need to get out and take a walk and go check on my neighbor around the corner. Or I do need to pick up the phone and call my friend that I haven't talked to. The other thing I didn't mention, which research tells us is really helpful for people with depression, is doing something for someone else. Depression kind of causes us to turn inward, and all we see is our own problems or this large rock in the road that I can't get around. And so when I start to think about other people, then my perspective shifts. We had this wonderful patient years ago, and when she was really discouraged, she would go and buy canned goods and take it and give it to people that she knew that didn't have food. And she did that because she wanted to help them, but she also did that because it made her feel better about herself. So I think there are deliberate behaviors that we can implement in addition to taking medicine or participating in formal therapy that will absolutely help with depression.
That's great. You said that depression can be diagnosed. Exactly. Is it just by going to a doctor and then you telling them that you are suffering from some of those symptoms? Is that how it's diagnosed?
A formal diagnosis would come from a physician. But I think most people, I'm not a doctor, most people don't present at their physician office saying, okay, well, Amy, I have insomnia and I've lost 15 pounds in the last 2 months. I think they come in and they say, well, doc, I'm just not feeling good. And or maybe I've had this life event. Because sometimes I think people don't really know how to explain what it is that they're feeling. They just know that things aren't right. So then sitting down with your practitioner and they ask you questions, and we do talk about, are you sleeping, and what is your energy level like, and have you really lost weight? And when we get down to some of those things, then it might be a mental health issue. Forgive me, I should have said that earlier. And I think anytime we have some of these changes in how we feel or how we're functioning, the first thing we need is a good physical. We need to go meet with our primary care provider and have them rule out some physical health things. There are thyroid problems and some of the other fairly significant health problems, uncontrolled blood sugar, that can really make you feel pretty crummy and mimic some of the symptoms of depression. So absolutely, the first thing we should do is go to our physician and rule out anything physical, and then we can move to if it's a mental health concern.
There are also some scientific scales that we use that ask those specific questions. So if somebody's kind of on the fence and you're not sure, then you can pull one of those out, and physicians will commonly do that, and therapists and other folks. So that helps you, and you actually score it, and then that doesn't necessarily always mean anything, but it does help you make that diagnosis.
Going back to the suicide, I just thought of something. So what would you recommend or suggest to someone that they've had someone come to them and say they're thinking of suicide? So like, I have a friend that's come to me, and I'm not a trained professional like both of you, and they're telling me they want to commit suicide. And what would you recommend that I do? Because a lot of us are not trained to handle that.
If you don't, my first suggestion would be, if you don't immediately know a practitioner, you can always call the hospital, and we would be happy to help you. Paula or I or several other people here. But if you find yourself in a crisis situation, Paula comes to see me and Amy, I'm thinking about killing myself, I'm here because I need help, you can dial 911 and contact the police, and they will send someone to help you. There's always a concern. I could say, well, Paula, I can help you get help. Let's get in my car and I'll take you to the emergency room. But there's always a risk associated with transporting someone who is actively suicidal. So that's why it is best to enlist assistance of multiple large people, perhaps, that bigger than me, on your side to help you, or use law enforcement or ambulance. And they are trained to help people who have these concerns.
That is correct. And one of the things we teach with mental health first aid, when we teach folks what to do when they encounter somebody in a crisis like that, is stay with the person. You don't have to have the answer, but stay with them and then pick up that phone and get a hold of somebody who will be there very immediately to take over and, do what needs to be done from a professional point of view. But you should tell the person, I feel compelled to do something to help you now, and I am going to call. You don't want to trick them or you don't want to deceive them, because that kind of, that doesn't bode well for the therapeutic relationship that you're trying to establish. So stay with them. That's the biggest thing. I'm not going to leave you alone by yourself, but help is right around the corner. Help is coming, and you're always going to be very happy if it's a good outcome. There are probably in the United States around 750,000 suicide attempts every year, and many of those patients survive. And they survive because they received the proper care and treatment and help when they needed it the most. So a suicide attempt is not necessarily always going to result in a death.
You touched on your mental health training.
Mental health first aid.
Why
Yes.
don't you talk about what that is?
Mental health first aid is it's a process that was developed in Australia probably 15 years ago and has trickled down into the United States over the last 10 years or so. And it's a concept like CPR. When somebody falls over and their heart's not beating and they're not breathing, we administer CPR, which is immediate first aid. So mental health first aid is a process that's based on that sort of a plan, where you're taught the ABCs of what to do if you encounter someone anywhere in your daily walk of life. It doesn't have to be in a professional setting. It can be at school. It can be at the grocery store, at church. If you encounter somebody that you feel like is just not behaving the way a normal person would, or maybe they're impaired, and you don't know what to do. So it's a one-day training session that you can enlist in to learn the ABCs of what to do. And it's really, really an excellent education. And it is for lay people as well as professionals, mainly because of stigma. Many people just don't understand what to do. They're afraid to do anything. There's a lot of stereotypes around helping people with mental illness. It's like Amy said earlier, if I talk to them about suicide, are they going to go out and commit suicide? And so we can answer many of those questions and just help educate people about what to do.
I'm going to go back to your two programs, Inspirations and Rising, because we've had a question and then there's a comment, and I'll let you address it. They were asking, are your programs free? Thinking back on that, someone just said, sometimes, a lot of people don't get the help they need because they don't have insurance. So either one of you can address that.
Well, for us here at Duncan Regional, we do have limited services. As we both mentioned, our services are for adults who are more geriatric in nature. They're 65 and older. And so that does leave gaps. We also, our inpatient program takes Medicare, but we do not take Medicaid. We're not equipped to provide that service for Medicaid patients. So, but that does not mean that we cannot help direct you to services where you can get help if you have limited or no ability to pay. So factually, I would have to say that we're not, in Stevens County anyway, we're not in an ideal place to provide care for those who don't have a payer source, but we certainly can connect you with those services in other areas, probably outside the county.
Do you want to mention about behavioral health, Dr. Jennings and?
Yes. We do have, we're very pleased that we have a psychiatrist who lives and practices here in Duncan. His name is Dr. Jeff Jennings. He is a board certified psychiatrist, and he does 2 days a week of outpatient care. So you can call his office, make an appointment, and come in and be evaluated and treated. And then 3 days a week, he works with the Inspirations program and follows those patients for med management. And then part of those 3 days a week, he also works in our inpatient program and takes care of treatment plans and medication management for the patients that are there. We also have Doreen DeLong, who is a very experienced psych, advanced registered nurse practitioner, lots of experience, who works in our inpatient area. We also have Kim Holland, who is also very experienced and works in the outpatient area as well. So we do have some resources available for those who need outpatient care, who might be younger than 65, starting about age 14 and up to 100 and whatever. So a broad range there of services available for a large range of ages. The number for Dr. Jennings and Kim Holland's clinic is 580-251-6644. So please take advantage of that if you feel like that might be a starting place for you. They are very busy, and you may have to wait a little while unless you're in a crisis situation. So I keep that in mind.
Well, we're about to wrap up, but I wanted to give you both some time if there's some other things that you feel that you would like to share about either of these topics or your program, because I feel this has been very informative for our audience. But I wanted to give you, if you have anything else that you'd like to say. If not, I'll wrap it up.
One thing, I think I didn't touch too much on the stereotypes that are placed on patients who have attempted suicide, but I want to be sure everyone out there knows that it doesn't mean they're weak. They could be very, very strong in their character, strong in their composition, and very accomplished. We've had that in the national news just in the last month with Kate Spade and also Mr. Bourdain, who was the chef who committed suicide. So it absolutely does not mean a person is weak. In fact, it is exactly the opposite. Most of the time, they commit suicide because they have untreated depression. So even the strongest of people can have life situations. We're all kind of a fine line from stepping over that and into a situation that could make us less than what we usually are in terms of being able to cope with things. So that's just one of the stereotypes that I think we need to really put to rest.
I feel, piggybacking on what Paula said, I think people sometimes have the perception that this is something that doesn't happen here, or it doesn't happen to me, or they set themselves aside. I don't know anyone that has that, or I'm not like that. And I think the reality is that it's here. It's in our community. It's in your churches. It's in our schools. And the greater knowledge we have and the greater willingness for us to discuss these things will help us help more people, and not just someone far away, but it really is our next door neighbor or our best friend or our child's friend that needs our help.
And this does touch Amy and I every single day, so we really want to get the word out. We want to be personal resources for folks who need help, and also professional resources as well. So thank you so much for allowing us to give you just a few little tidbits about these subjects that are so important.
Thank you. Don't forget to share with your friends to get your name in the drawing. Visit stopthestigmaok.com. There is a pledge out there that you can sign. You're not being committed to give money or anything like that. It's just a pledge about mental illness, and try to, as Paula would say, the stigma about it, that it's not a bad thing that you're suffering from some form of mental illness. And basically the pledge just says, I will provide a voice for those who can't speak for themselves. I will have the courage to speak up and challenge the stereotypes and attitudes regarding mental illness. I will serve as an example in changing the way mental illness is viewed. I will recognize my own prejudices about mental illness and work toward changing my own thinking and behavior. And I will choose my words carefully when referencing those with mental illness. So sign the pledge. We'll send you a bookmark, and you'll have the pledge on there. we'd love to get, it's a year-long campaign, we'd love to get at least 1,000 people to sign this pledge. But thank you, ladies. It was very, very informative. Amy has her phone number here for inspirations if you are would like to talk to her more. And Paula has, that's her phone number for the Horizons unit. And thank you very much. And we'll be back next month with another DRH Live.